Dr. Jifa. She's a director at Mitera Children's Hospital of the pediatric... the director of the pediatric cardiology department and adult with congenital heart disease department. And she's going to give us an invasive cardiology talk at the moment about the interventions that we can perform for the newborns.
Okay, thank you very much. It's very nice to be here with you today. I don't know if I have enough time. I'll try to speed up. Thank you for the invitation. So a little bit of repetition. We know that there is cardiac defects in infants are the most common congenital anomaly. Around 0.5 to 0.2 to 0.5% of newborns will need an intervention in the first year of life. And unfortunately, 24% of newborns are discharged undiagnosed, and some return in hemodynamic collapses. Now, we have to attend to children that have duct-dependent cardiac lesions, whether they are of pulmonary duct dependency or systemic duct dependency, and also lesions where we need adequate mixing, as Professor Carlyle said earlier on. So duct-dependent pulmonary lesions, it's severe PS, pulmonary atresia, TS, Fallot, Epstein, disconnected pulmonary arteries, and for the systemic circulation, critical AS, of course, very common, coarctation, interrupted arch, hypoplasty, and other single ventricle physiology kits. So most of the interventions in newborns are the balloon atrial septostomies, balloon dilation of aortic or pulmonary valves, perforation of pulmonary valve, RVOD stenting, PDA stenting, coarctation stenting, and PDA occlusion. So just let's see some examples. This is a baby who was detected antenatally with pulmonary atresia, and as we all know, the right ventricle was significantly hypertrophied, of small size, and of course, there's tricuspid valve regurgitation. And we took the baby to the cath lab in the first day of life, and the angiogram showed complete atresia. So we perforated the pulmonary valve and then started with a smaller balloon up to a balloon that was equal to the annulus. And these are the pictures. He had moderate PR, as expected, the right ventricle grew, and it's 5 years down the line, and he has not had any further either transcatheter or surgical intervention. So we were very happy with that, to get something out of a pulmonary atresia and duct septum like that. Now, there are other cases where the annulus is very small, or more complex babies, such as Fallot, where for some reason they cannot go to surgery immediately, and therefore we have to stent the RVOT or stent the duct. Now, ductal stenting has been described decades ago, so it's not something new. What is fairly new is which ducts are better to stent, and the interventional community are well looking into that. So ductal morphology plays a very important role. This is a baby with crisscross heart, disconnected pulmonary arteries with an RPA from a right-sided duct, where you see that there's a distal stenosis that came to our hospital in saturations of 55%, and in whom we had to stent the ductus that remained open for a long time until a surgical intervention had to take place. And another newborn baby who was found to be desaturated with about 90% saturations, who had a ductus that was about to close, as we see here. It was really tiny. We put the baby on Prostin and stented the duct after we managed to open up this thread a little bit. And you see the stent here on echo. And then the right pulmonary artery distal grew, and at a later stage, we brought the right pulmonary artery to the confluence, and therefore we had an excellent result, and the child has remained asymptomatic ever since. Now, in conferences, we used to talk about our successes and less about our failures. So I'll show you another child with whom we weren't happy, really. So this is a Fallot child, 3.5 kilos, failure to thrive, severe desaturations of 68%. And he had a very, very tight RVOT, small pulmonary valve. RVOT stenting was not in the cards. And then we discussed about BT shunt versus PDA stenting. And you see here that the PDA again is about to close. And what we see in the left lung, if I'm not mistaken, is mainly the left lower lobe, and the rest of the vasculature is pretty bad. But we thought, well, we can get something out of it. And we talked to the surgeon. We said, we're going to stent that. So this is what we did. And we stented that, and we were pretty happy. And as we were about to leave the cath lab, the child desaturated again, and the stent had occluded within 20 minutes. We then did a balloon dilation with a high-pressure quantum balloon, and then we had to stent in stent with another 3.5 stent, and that occluded within the next 10 minutes, and therefore we had to take the child to surgery because now the saturations were even lower. The surgeon did a complete repair with a transannular patch, but we could not wean the baby off bypass, and therefore put the baby on ECMO. On the fifth post-operative day on ECMO, we could not see the left pulmonary artery. Of course, the chest was open, but we had significant suspicion that the LPA had occluded again, and therefore we took the baby to the cath lab on ECMO. And you see here that the LPA that the surgeon hadn't really touched very much here, had occluded. And we, under ECMO, put a stent, which was the Liberty stent, the Rebel it's called these days, 4.5 millimeters by 16 millimeters. We're pretty happy, patting ourselves on the back and say, right, all right, he's going to be okay now. And then he went off ECMO after that very quickly. So that was a good procedure, and went home 2 weeks later. However, on echo, 4 months later, the LPA flow could not be seen again, and we recut him here, and we saw that the LPA stent had now rethrombosed, and the vasculature again to the left, the perfusion was really bad. So the contegra, as a result of the obstruction, had dilated a lot, and so we went to surgery, changed the contegra for an aortic homograph, and the LPA stent was removed, and the surgeon put a P-patch all the way to the hilum, and was pretty happy with that. And then a few months later, again, the LPA could not be seen, and we did this MRI, which showed that there was really no perfusion to, well, no flow to the left lung. And the QP of the pulmonary artery was exactly the QP of the RPA. And therefore, for the last time, we took the child to the cath lab the other day, we measured RPA. Small occlusion of the ostium of the LPA, and this is what we got. We got lots of bronchial arteries, but good feeding vessels through this mesh of collateral, so that the pulmonary veins, the venous flow was very good coming back. And I think that's the last we got from this LPA. Now on to more jolly and successful things. This was a fetal aortic stenosis at 22 weeks of gestation, where the left ventricle seemed to be small, albeit that was contracting very well. The mother was very religious and therefore did not follow the doctor's instructions to come back for a repeat scan. And she appeared at 33 weeks of gestation now with a left ventricle that had ballooned up and did not have good function anymore. The baby was born electively at 33 weeks of gestation because this was beyond the age that we would perform a fetal intervention. And initially, the saturations were 45%, and one was contemplating whether we should do anything at all because of the condition of the baby. And we took him to the cath lab because the parents really wanted us to, and we wanted to. And this is the left angiogram, the ventriculogram, which shows the appalling left ventricular function. But we ballooned that, and we were surprised to see that this stand LV picked up a few days later to this level, and therefore we were pretty happy with that. But more babies are coming to us collapsed, like this one, who was Learjet to us from another country nearby. And you see here that although he has aortic stenosis, and of course we knew that, what we didn't know in the initial aortic angiogram was that there was an occlusion in the right coronary artery that one can see over here. We did the ballooning of the aortic valve on rapid ventricular pacing, and the baby, of course, went into VF during pacing and had to be cardioverted. Everything went well, and I think with this cardioversion or for any other reason, at the end of the procedure, we could not see any RCA thrombosis anymore. The baby is fantastically well 5 years later. Now, there are a few babies that are borderline, as we know. We don't know whether they will achieve biventricular repair. This is one of them with borderline LV. His initial MRI showed the left ventricular volume being 17 mL per meter square. We allowed the baby to stay on prostin and allowed the left ventricle to load, to volume load. And the next scan, 2 weeks later, showed an LV volume of 28 mL per meter square. And therefore, we attempted biventricular repair. On this picture, you see the ductal arch, and here you see the small ascending aorta and the true native transverse arch. And this was, of course, repaired. So that was extended arch repair from the front. But then the baby needed a ballooning of his aortic valve as well, although that was small, 6 millimeters. We ballooned that with a 6 millimeter balloon under rapid ventricular pacing. And this is years later when his left ventricle seems absolutely normal, no size discrepancy, the aortic valve is good, and there is no aortic valve regurgitation or gradient produced by the pacing. Now, there's hybrid procedures for the ones that will not be able to go to biventricular repair. These have been described decades ago. Dick Bashans and his colleagues have extreme experience with that. We have very few hypoplasties that will go down this route here in Greece, but certainly for the ones that are born and the parents want to proceed, hybrid procedures or branch PA, standing and other more new technologies are there to serve the patient. Difficult coarctations for babies. Well, we know that babies in the first year of life will have a surgical procedure, but some are extremely difficult, like this Williams infant, 6 weeks old, had a surgical repair. And unfortunately, because he was Williams, there was severe stenosis, and on MRI, we could really not see a true lumen. So we took the baby to the cath lab. Unfortunately, there were occluded femoral arteries, and through an axillary approach, we put a DES stent, a drug-eluting stent, and you see here the result, the long segment stenosis, and this is the result following the DES stenting. And this is something that we use in neonates. Of course, newer stents are coming into the picture. Biodegradable stents are something that has been long researched for. Mazenia Alwi has a lot of experience. You see here the recent paper with PDLA zinc stents that at 24 months, 2 years later, they biodegrade. And this is a fantastic option for newborns. And lastly, the neonatal PDA closure. Neil Wilson started that in Oxford in mid-2000, and he used coils and plugs. Joachim Miro from Montreal started in early 2010, and now there's quite a few centers around the world that will attempt neonatal PDA closures with the small Piccolo device mostly, but there is also the Medtronic vascular clamp. The Brompton have enormous experience, and this is courtesy of Alain Fresh from now on, what I show. They have done over 100 cases since 2016, median weight of 1.3 kilos, starting from 740. And worldwide, there is more than 800 cases in the US, 500 cases and more in Europe, etc., we need to have a PDA diameter less than 4 millimeters, length more than 3 millimeters, and a weight above 700. So these are a few cases that Alain has done, not only at the Brompton, but also in France and other places around the world where he goes and proctors these cases. And he says that even such ducts that look pretty enormous can be dealt with by a transcatheter approach. And he also says that when there is a residual flow, one has to be patient, and the flow might really go away after the procedure within a few days. So the procedure is the same like we do with older patients, and what is really important is that the vascular access, the venous access, is done under echo guidance. And of course, these do not go without complications. Complications of such interventions in neonates are perforation in tamponade, number one, malignant arrhythmias, I alluded to one, loss of cardiac output, stent or device embolization, obstruction of neighboring structures, and of course death. But we do them when there is a hard team decision and our surgeon, like in the case that I showed you, says that he could not do better than us and he will be on our side in order to do something like this and in order to have improved morbidity and improved mortality. And that defers the surgical procedure to a later date when the infant is bigger and stronger and it proves therefore the long-term prognosis. But these procedures are not very common and they should be done at expert centers by dedicated teams that do high volume of neonatal procedures, and very important that they have a neonatal ICU and neonatologist to care for these patients before and after the procedure. With new techniques and materials that are steadily increasing, we feel that we will increase the possibilities in our procedures, the range of procedures. We use now new coronary stents, drug-eluting stents, and hopefully biodegradable stents, drug-eluting balloons as well, smaller closure devices. And we have to join our experience between other centers because, as I said, the number of cases is small. And before I close, I would like to acknowledge our NICU staff. We are lucky to have the largest ICU in the Balkans with 60 ICU beds, and we could not do these procedures without them. Thank you very much.
Thank you for the excellent talk with all these procedures starting from 700-gram children. Do we have any questions from the audience? Of course. Go ahead.
Aphrodite, great talk. Thank you. Here's Dietmar.
Hi, Dietmar.
In summary, what is your summary? Which patient do you send to surgery, with exception of the TGA maybe, in the newborn area with congenital heart disease?
Diagnosis, depends on the diagnosis. I mean, we can talk about diagnosis separately. For example, do we talk about PDAs?
Do you send any for prophylactic, as a palliative treatment always? So not always, but mostly, with exception of the PDA. Which patient do you send to surgery, and do you have still patients? I cannot remember me directly, but maybe what is your experience in this?
Well, I think you cannot answer this question in a generalized manner. We go to operating theaters when we feel that the procedure that they are going to do is definitive for the patient. We do not want, and that is the current trend, to have palliative procedures.
Okay.
Any other questions?
Thank you.
Dr. Ramos, do you want to have No? As an invasive? No. That's okay. Thank you, Aphrodite, for an excellent talk. Then we have to close this session with remarks. First of all, I'd like to thank all the speakers for the excellent talks. There were wide topics and excellently presented. We've seen from the beginning the evolvement of the fetal heart up to the scanning during pregnancy and the management after pregnancy. Would anybody would like to make any other comments? No, that's fine. We'll go for a coffee break.